Hey there, welcome back to the Joint Dynamics Intelligent Movement Series podcast. My name is Andrew Cox. I'm one of the owners and directors of a company here in Hong Kong called Joint Dynamics. And I'm also the host and curator of the podcast. What a great job, let me tell you, because today my guest on the Joint Dynamics podcast is Dr. David Owens. Let me tell you about David. So David qualified in medicine from Leeds University in 1984. He's practiced medicine in Hong Kong since 1988 as co-founder of OT&P Healthcare. He's an honorary clinical assistant professor at HKU, fellow of Hong Kong Academy of Medicine and chief medical officer for the Hong Kong-China Rugby Union. He's done 20 years at the Hong Kong Sevens as the doctor there. He blends family medicine and sports medicine. He's treated everyone from elite athletes, pitch side and in the doctor surgery, to professionals and everyone in between. Welcome, David.
Cheers, Andrew.
Hey, you know what? I've got a story, personal story. When we had I don't know if you remember this, but when my wife and I had our first child, my wife is very ambitious and she was torn between being a mother and being someone at work. And it really played with her head. Like she wasn't feeling good. Anyway, we went and saw you. I don't know if you remember this. We went and saw you. You gave us so much time and it changed my wife's perspective. If she was here right now, she'd probably give you a kiss on the cheek. No joke. That's a true story. So that was 17 years ago, mate.
Yeah,
thank you.
Interesting.
Well, been waiting 17 years to say thank you. Thank you, David. Thank you, mate.
Well, you've helped me with my fitness over the years.
Well, you give, you receive.
Give. Exactly. Yeah.
Amazing.
You give, exactly. It's all about giving.
We were just discussing, there's many things that we can dive into, in particular, the evolution of medicine from 1984 to today. Some interesting stories from your work in the rugby union at the elite levels that you've been at. And then also in the gym, this whole conversation started around this magical thing, often portrayed as magical, zone 2 cardio.
Yeah.
We can go through those one at a time, but I think that a great place to start is, from your perspective, being involved as a doctor since 1984. How has medicine changed from 1984 to 2026 in your eyes?
Oh, well, there's been a big change, of course, in medicine. When I qualified, there was no internet. HIV really had only it hadn't been coined, that the phrase hadn't been coined, but the illness had been recognised. I saw my first case in 1982, actually, in the West Indies. In retrospect, we were pretty primitive in terms of treatment modalities, very much disease focused. And I trained in a system-based disease model, the cardiovascular system, the respiratory system. And that's still the case today. And I don't think really modern medical training has adapted to the changes in, we talked about this before, that philosophically, I view health, not disease. The role of a doctor is increasingly going to be facilitating decision-making and behavioural choices which lead to increased health. And health is not the opposite of disease. Health is a positive construct. And we often talk in the old paradigm, I think medicine was about hospitals and cancer and surgery. And we saw this with COVID, too much of a focus, in my view, on the disease model. And I think as we move forward, one of the things that's happened is we've increasingly understanding that, the biology of modern diseases, chronic diseases, of heart disease, of diabetes, of cancer, neurodegenerative diseases. These diabetes, these are diseases of lifestyle to some degree. They're diseases of accelerated aging related to chronic inflammation, to cellular damage, to damage to energy systems. And in some ways there's a crossover there between that model of health and what we see when we're dealing with performance athletes. I don't think you can completely cross over, and this is one of my slight bugs with the zone 2. Maybe we talk about that later, but
maybe
I think or now
No, let's stay on this because it's. I'm super interested.
Yeah.
One of the things that comes up, popular press or where we absorb press from nowadays is often through social media. And often on social media, it seems as a way to raise myself up the hierarchy of I'm important. Often you will hear, whatever an influencer is, but I know I've heard people that I would term influencers, doctor bashing in the sense of, well, doctors only look at this system, the cardiovascular system, in isolation. They don't look at it in integration, and biology is an integrated system. It's a system of systems. What would you say to that? Because when you were talking about that, I just, in my head, I heard those terms echoed.
Yeah, I mean, I've got some sympathy with that criticism of the medicalization of life, the pharmacological focus on disease. I think has driven some of those negative perceptions. And if I was being critical of my own profession, I'd say that it's almost a truism that the single most common conditions affecting individuals in specialties are of no interest to the individual specialists. So gastroenterologists have no interest in irritable bowel syndrome, and orthopedic surgeons have no interest in back pain, and gynecologists are not really interested in perimenstrual pain. These are sort of common functional conditions which are sort of dismissed as, well, yeah, they're problems, but they're not disease. Okay, and so I think we as a profession probably do share some blame in going along with that sort of disease-based focus, and we see it now with there is a little bit of a default position that I've my cholesterol's 242. Do I need to take statins, doctor? Or I've got, well, yeah, maybe, but and I'm not knocking the value of pharmacological interventions, but maybe, mate, you need to just get out and do a bit more running and lift a bit of weight and eat a bit healthier. And in population terms, that's going to make a bigger difference.
Is that often the first port for you? I'm assuming that might often be the first port of call. But again, I'm sorry up front for saying this loaded question. If you were to speak on behalf of your profession, would you suggest that what you just said, the pharmacological intervention, is potentially the easiest one? It's validated from certain scientific literature, so it's validated. Would you often say that is the first point of call, or as you just suggested, you know what, mate, often how about this? You go try and get fit and healthy a little bit, and then we'll discuss. If nothing changes, then we'll discuss. Or is it more urgent? Because in your head, the equation that you have is different to the equation that I have in my head, David. You're thinking, to some extent, I'm imagining, is this person going to die if I don't do this? Is that to the extent of where the way that you manage your risk analysis?
Well, I think medicine is a reasonably large spectrum of career choices, and I don't want to be perceived as being critical of my profession. I'm definitely not. I love being a doctor, and I wouldn't want to do anything else.
Thank God you're out there, mate. Seriously, thank God you're out there.
My eldest son is an emergency physician, so he works in a pre-hospital care at a sort of super acute end of. Effectively, his patients are going to, without treatment, may well die in the next 20 minutes to an hour, or they're probably not his patients, sort of thing. So when you're dealing with that end of medicine, very definitely you need medical intervention, you need quick decision. Yes, you need pharmaceuticals, you need interventions, you need procedures, and you're not going to, stop and debate lifestyle choices. So likewise for, maybe some surgical conditions. And so there are areas of medicine in which yes, hospitals are important and urgent response is important. In the field that I work in, primary healthcare, we're really dealing with complex interactions of genetic factors, lifestyle factors, behavioral factors, and these play out over time. So I tend to be dealing with longer term issues, longer term risk decisions. Do I take a statin to lower my risk of heart disease in the future? Do I take this medication to reduce my complications from diabetes or whatever those things may be? And yes, you're also, depression, psychological illnesses. I would argue that there's in this broad realm of medical conditions, many of which are chronic medical conditions, we've probably underplayed the value and role of non-pharmacological interventions historically. There's a very interesting review in the British Medical Journal from February last year, and you can post it in the links that summarises different non-pharmacological interventions for depression and anxiety. And exercise is way more effective than the most effective drugs that we have. But interesting, the most effective subtype of exercise in this particular cohort was dance, actually.
Really?
Yeah, dance is
Is
amazing.
that because there was interaction with another and you got to learn things so that the brain is forced to learn complex patterns? And
like that particular area is sort of it's outside of my expertise from an academic perspective. I've got a few theories and interests about the process of movement, engagement with the music, of focus in, as you say, working with other people, the sensual component of it. Maybe there's even something about the studies and there's confounding factors, but we know that movement with a meditative component of focus, exercise in nature, that's one of the key things that's been shown to make a big difference. So I think when I'm a big behavioralist when it comes to management of depression. I'm not saying that antidepressant drugs are not effective. They can be very, very effective, as can cognitive and psychological interventions, but doing stuff makes a difference. And I've always been a kinesthetic, a doing person. So I think maybe if I think in terms of the next generation of doctors, and I'm involved a little bit in teaching, my focus would be on growing out the component of the medical intervention sort of armory outside of just drug treatment, and I think we're beginning to see this now. That my postgrad is actually titled SEM, which is sports and exercise medicine, and there is a focus now on how do we dispense exercise, how do we give advice in a more structured way rather than just saying, like, mate, your cholesterol's high, just do more exercise. It's like, well, what exercise? Okay, what does that mean? What does it look like? Because as you know, it's different for different people, isn't it? So,
isn't that? Do you know when my mind just went cross-correlating everything that you've said? It's hard to quantify. Just say someone comes in and you say, well, you can't just say just go exercise because it's what do you mean? Quantify, and then but you could say, we'll go join a dance group. You know what I mean? It's more bespoke. You can understand, but for a certain individual, that would be the best thing is to, as far as your directions or the exposure that I want you to get, mate, go join a dance group.
Yeah, exactly.
Do you remember on the mental health thing, there was a big study, it's growing, but there was the Duke University study with that, I think it was James Blumenthal et al. It was one of the breakout ones, and they did pharmaceutical intervention, exercise and pharmaceutical and exercise only. And they all worked at the initial, and then towards the end they found that this was, I forget the rate of depression. It wasn't psychotic. It was, it was not severe depression, but it was depression. There was a certain category in which they put them in. But anyway, when they revisited the study 18 months later, here's where the big kicker was. Exercise outperformed. The others did well, but exercise outperformed. And one of the reasons that the researchers said that came up was that people felt that they had self-control via me taking control of my own health, my own condition, and via exercising, I have self-control. So I feel like I can control myself a little bit better. That was one of the reasons that came up in that research. Yeah,
I mean, I think from a psychological perspective, one of the key factors in my experience in depression and anxiety is lack of control, change, and uncertainty. And from a philosophical perspective, I would argue that the role of a doctor or a therapist should really be to transfer control back to the individual, to tools for your toolbox to work on this going forwards, rather than I think medications can be helpful, but we have to be careful that they're even the explanation and education is given in a way that reestablishes that sense of control. And so exercise in groups, exercise in nature, being part of a team, these are all like key factors in recovery. You know, one area I'm quite interested in, this could be subject to some degree of bias, recall biases, or any of the sort of cognitive biases, to be honest. But I work with both the men's rugby team and also the women's rugby team, which is a sort of, you mentioned the length of my career. I'm an old fogey. I came from the days of the guy with the sponge, as we talked about earlier.
The magic sponge. I was baptised with one of them, David.
But over time, there's been more science in the game, as we've talked about that a few times before. I do really like working with the women's rugby team, and I find that again, I'm saying this may be a bias, I find that the team dynamic and the team connection is almost more intense. And when I'm managing things like concussion or injury, it's a real challenge to integrate and maintain integration into the team, because being a part of that unit it can become an integral part of the identity of an athlete, or especially, well, not necessarily especially, but it certainly happens in elite athletic performance. And it's one of the things you have to think about when you're rehabilitating and pulling people with, for example, with concussion, which is a big issue. We're pulling players out of their team environment. They can become isolated, and I definitely see, I believe I see, a fair amount of depression and anxiety as a reaction to that. How do you manage that? You don't want somebody to be getting banged on the head, because we don't want to increase their risks, but you want to keep them a part of an integrated unit. So,
can you give me an example of how you have managed that?
Well, we try and through the programs, and our physios are fantastic at this. Of course, we try and keep players integrated into. So it's obviously non-contact. We now manage concussion in a much more structured rehabilitation. So there's the old days of go and lay in a room, a darkened room, and don't have any cognitive stimulation and no physical stimulation. They've sort of gone. We have a graduated physical and a graduated cognitive response. So the players are integrated, but they're just taken out of contact, and they're involved, maybe not necessarily in team meetings, but you do obviously end up with situations where, say, a team's traveling. If you've got players who are not going to be able to travel with the team, so maybe you've lost your position in the first team. That can be a big issue. If you're
100%,
if you're professional, your life is dependent upon what happens. So we try and keep people integrated, even if it's in the non-traveling squad. That's you want to be around the team environment, still doing stuff in the sport. So that's an interesting area. I'm not sure how we jumped onto that, but it's we started, didn't we? Well, I think we just before we started the video, we were talking about in 1991. I was a GP trainee. I had a slightly unusual training program, because I came to Hong Kong as effectively a TB doctor. I was a chest doctor, and I won't bore you with that story. But I went back to the UK and did. I retrained in primary healthcare, having left hospital medicine, and as I was doing my GP training, and I had two small kids at that point, and I was working in a general practice in Otley, which is a little market town in the north of England, and famous in rugby circles because it's the ground in which the north of England beat the All Blacks when I was a student, actually, in 1979. It was a very famous match. And then it hosted a game in the Rugby World Cup. And my trainer was, he was my GP trainer, was a member of Otley Rugby Club. And he got asked, could he provide a doctor for the match? And he got a bit freaked at this and said, "Oh, I'm not sure. Like, you've done more. You're more interested in it than I am, and you've done more recent emergency stuff. Can you do you mind covering it?" So I no worries. So I grabbed a medical bag and went down to the pitch and on the sidelines, and Italy won convincingly
Against who?
Against America, actually,
Yeah.
US, United States. So that was my first. I'd done a bunch of rugby matches before, but that was my first World Cup match.
What did you learn from that one? Do you remember?
Well, it was a little bit intimidating at the time because I learned that the guys who were really supposed to be doing the job were in the bar drinking beer with the
1991, ladies and gentlemen.
1991, yeah. And I had this conversation with James Robson. Like those who are keen on rugby would know James he's a British Lion. He did the British Lions doctor, and he was a Scotland team doctor, and he's been a mate of mine for a long. We've done some courses together, and we've known each other for a long time. And he and I've talked about all. Like, obviously, he had a much more serious career than I ever had in team sport, but our transition was over the same time. Yeah, and so he started as a physio, and we were actually at it doesn't really matter. We were both teaching at something not too long ago, and we were reflecting because the last World Cup match I did was in 2019. The Japan Ireland game. Actually, I was the match doctor for that game, and that in the intervening time, like from
27 years. Hang on, 1991 to 2019.
Oh, you'll be better at maths.
91. No, 8.
I'm an old bloke.
Anyway, it doesn't matter.
It was a long time.
It was a long time. Yeah, 28 years, something like that.
Yeah, 1991 to 2019. It's probably not that many people have had a World Cup career that's that long, actually.
And here's another question then. So I asked you how medicine has changed since 1984 to today, 2026 it is, ladies and gentlemen. How had rugby as being the pitchside doctor from 1991? And just a small observation, if ever there was a conclusive study of the power of placebo, the rugby magic sponge is the number one. A dude could have a broken leg and you could run out and rub the old magic sponge and then he'd drink from it. That's what I used to play rugby league. Same thing. You'd see the guys, we'd be running back, someone would be injured, they'd rub the sponge on your elbow, your head, whatever, and then they'd dip back in and drink from it.
Right,
I was like,
exactly. That's exactly.
Exposure therapy to bacteria. It's a whole vast array of treatment. Sorry, back to the original and the serious question. How did rugby change as a pitchside doctor from 1991 to 2019?
It's just like, it's chalk and cheese. So Japan, as an example, there was probably, I don't even know, right? I was the match day doctor in Japan. Well, I can tell you for sure, I was the match doctor, so I was effectively the referee responsible for the management of concussion and head injury. Okay, that was my role. Both teams had so there's an Ireland team doctor, there's a Japan team doctor, both of whom I knew. There's a doctor for trauma for the pitch. There's an orthopedic team. There's an extraction team. There's a dentist. There's
a dentist as well.
Oh, yeah.
Makes sense.
So we probably had. I'd be surprised if there wasn't 50 doctors in the stadium for that match. And
1991, one.
Yeah,
and some at the pub. You established.
Pub, yeah. I'd be surprised if. And we had I went to Japan 3 times to prepare for that one match. Yeah, I went to Japan, we had training. We have a very good relationship with Japan Rugby Union from Hong Kong, China Rugby Union. We've had pitchside training programs. Lady, you and I both know, Lucy Clark, who set up the training programs for Hong Kong Rugby. And Lucy and I both sat on the World Rugby Working Group that developed pitchside trauma standard practices. This was more than 10 years ago. And Hong Kong had an affiliation with the UK program, England Rugby, not UK, it was England Rugby, through a guy called Andy Smith. Andy gave us lots of support. And so we had a whole bunch of doctors who would come from Japan, and they'd run training programs here. And then we did some head injury training and concussion recognition training coming up. So there was, it was a 3-year lug-in in terms of the training of medical, not obviously the training for the tournament was going on, and that was driven by the fact that I don't even know the timings now, but at least 15 years ago, World Rugby started a medical commission, and there's a once yearly gathering. There's a bunch of doctors who pretty much only focus on research in rugby now. So it's become
really,
there's a sports science focus on. Yeah, I mean it's and I think rugby. I'm slightly biased because I've been involved in it, of course, so I'm definitely biased. But I think it's fair to say that rugby's certainly up there in terms of the top sports, at least in terms of audit and recognizing and understanding the associations of risk with different aspects of the game. We know very clearly the incidence of per 1,000 player hours of different conditions. That we know which positions are more vulnerable to which types of injuries. We know what type of tackle is great, and that's where the changes in the game, for those who've been interested or will follow it, will see the different experiments with law variations around tackle height and sanctioning for different varieties of tackle. They're based on an evidence and head injury assessment, which is, I mentioned, was the job that on that particular match I was overseeing, and I've done it like many times with Hong Kong as well. I think many people don't really necessarily realize this, but HIA, or head injury assessment, is part of an ongoing trial which is undertaken by World Rugby. So when you're in a match and you see the referee tap their head and the player goes off and they get tested, they go through a very standardized process of testing, and then that's repeated before they leave the stadium, and then it's repeated within 48 hours. And so the HIA1, HIA2, HIA3, and then all of that is audited and published. And so, we know how many players get concussed, which position, which type of tackle, and it's a much more scientific process. It's an evidence-based process to some degree. I think it's not completely without.
There's an element of chaos involved in the game that's hard to quantify, would you say?
Completely, and I think one of the challenges is there's been an attempt. I'm getting into sort of slightly controversial areas here, and it's I definitely don't want to be critical of of all the work that's been achieved. I think if I would have an argument, it would be that we've tried to manage the process too much by sort of algorithm and if A happens, if B happens, if C happens, and I can see why you need to standardize, but having if you're there as a head injury assessment doctor, you are literally making a decision on 0 to 2 seconds, 2 to 5 seconds, 5 to 10 seconds, 10 seconds and beyond. And there's different criteria you're looking at, and I think when you get to this stage where you're looking at the referee, you remember this from the World Cup, is he bent at 45 degrees? Yeah. I'm not certain that we haven't just tried to. I can see why, but I can see why we're trying to standardize to some degree, and it's important to try to reduce the amount of head contact and reduce the risks of concussion. But I think that to some degree we've over medicalized it. We've anyway. That's
in my head as I go through and we sort of said a little revision almost what we've done so far. The evolution of medicine from 84 to today, and then the difference between as a doctor on the pitch side between 1991 to 2019 with Japan. And then I go, imagine, David, if we had sat down and we watched the 1991 game, and then the very next game we watched was a 2019 game. That would be vastly different. One of the pleasures I've had of having a podcast was I got to interview Nick Gill, Dr. Nick Gill, who's the strength and conditioning legend from the All Blacks, taking them to 4 World Cups. And he said to me over his career working with the All Blacks, he said, year on year, the forwards have become a kilo heavier while maintaining, if not increasing the same speed, and while maintaining, if not increasing skill. So you've got bigger men running at, if not the same speed, faster speeds, and with the same skill set. So even from a mathematical equation of systemizing forces, mass times acceleration, you know what I mean? And he sort of suggested since the start of his career working with the All Blacks until where he is, that was last year, I think it was, he sort of said the nature of injuries that he'd noticed, they've changed from more soft tissue. The guys are really very well prepared. The training has also evolved, and maybe that's why they're getting bigger, faster, fitter, stronger, But he said the nature of the injuries he's found is we find we're getting more broken bones and more serious injuries and less minor soft tissue injuries is one observation that he was making. Due to the size in the forwards, the size of the forwards guys getting bigger.
Yeah, I mean the game, it's progressed from a contact sport to a collision sport.
Yeah. And they are athletes, David. Like, not saying they weren't in 1991, but I'm pretty sure if 100 of us watched 1991 and then the same 100 people watched 2019, I reckon 90, apart from the emotional connection, I reckon 95 of us are going to say, mate, they are so much better athletes in 2019 than they were in 1991.
Yeah, absolutely. I mean, I can't remember the exact dates of this example. Actually, it takes away from slightly, but it was one of the senior French scrum coaches told me that they'd looked at the forces through the front row and the Six Nations under 18 team had generated greater forces than the national team at 2004, 2005.
Yeah, that's crazy.
So it's like that. So, and one rather simplistic way of thinking about injury, it's actually it's the way I think about injury, because I think it could be quite a helpful model, is application of a force to a tissue beyond the ability of the tissue to absorb those forces. So, I'll often talk to my patients in these terms. If you imagine taking a branch or a stick and you bend it, and you can bend it and it'll adapt within the forces applied until you take it past that threshold and it snaps. And that tissue can be damaged when that force is applied as an acute single macro event.
Yeah.
And so we see, the broken leg. I was running down the wing and I got tackled by their 7. He was offside at the time. It was a Perpignan guy. Yeah, he was. We were 15. Yeah, that very precise history. Yeah, it's single event, and at the other end of the spectrum, we've got the repetitive overload, the repetitive micro trauma. So those front row type of injuries. Yeah, we were always early in my career. The big focus was on a catastrophic injury, which of course by its nature and definition is catastrophic and life-changing and terrible. But you also had the chronic neck degeneration and spinal degeneration related to overload, both through the front row. But in my own sort of day-to-day sports medicine career, probably 80 to 90% of the overload injuries I see are the injuries I see are overload rather than acute macro injury. It's as we both know, Achilles tendinosis or knee pain, especially in female athletes, but not only, but heel pain.
Yeah, that Q angle that we talked about.
Exactly, and we also know that. Again, this comes into the area we've spoken about a lot because we're both so interested. We've both got an injury prevention focus, haven't we? And so, acute macro injury, we estimate that we can prevent anything up to about 80% of those acute ACL injuries. It's like we can probably prevent 70 to 80% of ACL injuries with good quality strength and conditioning. Because 80% of ACL is non-contact, which is crazy, isn't it? It doesn't happen you're on your own. You don't get tackled. You just twist or
that plant that foot, change direction,
and it goes. So we know that we can significantly reduce those injuries, and we know that we can significantly reduce the overload injuries by managing the load and managing the underlying biomechanics, the movement patterns. And this is the thing that
that's the magic of it, isn't it?
That's the magic, isn't it? To and if you do that, where I think sports science has helped in rugby and other contact and collision sports is if you optimize biomechanics and movements and you make people strong, the forces are greater. And so the potential for injury is greater. But if you're matched,
the strength of the unit,
and you have the strength, you can adapt to it. Yeah. And of course, from a coaching perspective, the single biggest risk of injury is previous injury.
Yeah.
So if you've got the
stats behind knees. Yeah.
So
or whatever. Sorry.
Whatever it might be. Yeah. It's like I chatting to a young lad a couple of days ago, with a classic bit of an AC joint injury. It's like, if you're going in trying to tackle off your left shoulder, but it's feeling a bit sore, so you're trying to get round and tackle with your right. You cop your head and then you get a concussion. So you want to. You want to manage injury and rehabilitate injury, but the second commonest is mismatch, and of course, coaches are looking for mismatch. So, if you take a big,
it's like the ethics of a shark, isn't it?
It is.
attack the wounded, the weak.
Attack the weakest.
You know what I mean? But it's true.
Well, that's like I've done a bunch of these coaching courses and I've taught on them. Yes, like you that's what you're focused on. Identify a mismatch. You want your fast guy running against their prop,
especially if he's fatigued. That you highlight that. That's right. A good player knows that, huh?
Yeah, or you want your big guy running at the little guy. Yeah.
You'll get short turn, mate. Don't worry. Karma plays itself out very well on a rugby pitch. You know what I was going to add? One of the working thought bubbles that I carry with me on injury is exactly what you said. An injury occurs when force exceeds the current tissue tolerance of the body, and that's also on a spectrum because the more fatigued you have, that there can be less tissue tolerance, and then also sort of condensing what we sort of said and the body's ability to adapt, and that's where we have skill development. So if I'm tired and I haven't put myself in these positions regularly where I change direction, if I'm just a linear trainer, a 100-metre sprinter, and then I go play rugby, and if I'm not quite as fast as a 100-metre sprinter, but I do a lot of change of direction sports, and my ability to adapt when I change direction is better. So that's when the development of skills and preparation of the body and tissue tolerance comes involved with that idea. That for me, the working idea of what is an injury, and then if I can understand what an injury is, then I can re-engineer it to try to reduce the likelihood of injury.
100%, yeah. Focus on those movement pattern.
The holy shit, we sometimes call them, David, through Dynamics, we call them the holy shit positions. So you can put someone in a holy shit position, knees get over the toes and just rotate away. So there's that collapsing in. You can put someone in a holy shit position, get them comfortable and confident, with the idea that maybe this will translate. And we also have another working model of the body's a collagen generating machine, and the body lays down collagen in response to stress. So if collagen is the most prevalent protein in the body, if I can put a line of stress through the body, we know that's how bones are remodeled, and we know that's how soft tissue is remodeled. If I can put a line of stress in, there's a theoretical thought in my head that says, well, the body may indeed lay down collagen to respond to that, so to strengthen that pathway is one thing that we play with as a working analysis.
Yeah, I guess
the timeline is nebulous. I honestly don't know, David, but
I have
the ability to be able to get there and come
model
out.
In that, the injuries, I'm often telling people injuries responds better along the line of tensile forces. Yeah? So we know that you need to put the tissue through some stress to get, you want muscle injury in particular, tendon injuries. You don't really want the cross-linking and scar tissue.
Yeah, type 3, you want to, exactly, type 3 collagen,
So yes, you need to load, but not overload. Yeah.
Thank you for saying that. But that's Davis's law. Do you call it Davis's law? Tissue will remodel along lines of stress.
Yeah.
And then Wolff's law is function governs structure. So you know what I mean. Just get out there and do it, and your body will respond.
Well, I guess these are all. That's the principle of training, isn't it? Overload.
But not too much.
Recover and adapt. And then go again. And that
that was perfect. We just summarised my whole industry: overload, recover, and go again.
Yeah.
Full stop. Boom. Good night, everybody.
And well, I guess the devil's in the detail as always. And what does not overloading mean?
Yeah.
And what does recover mean?
Yeah.
Go again's easy. That's just go again, isn't it?
Yeah. And actually, that's a really good point, and actually can lead us on to the Zone 2 discussion. But the go again, I'm going off popular press, and there's some amazing characters which are putting out powerful messages to people that are necessary as well. Like, potentially there's a portion of the population that are too soft, and there's this need and a Goggins-like character that just says, get off your ass and do it, no matter what. There's pros and cons to that. Thankfully, when you work in a one-on-one environment, you can control those variables. But there's a need and there's a danger as well in that philosophy. And I see you screwing up your forehead, mate. Go on, let me know what you're thinking.
No, I guess there is, and there's also an individual approach, as you said, is like one-on-one individual, and then there's a population-based approach.
Yeah,
and then one of my, I guess, slight beef with the modern soundbite, like health influencers, is mixing up all of those different messages. And I guess I'm a bottom up guy, so from a philosophical perspective, I think it's probably more important to get 1,000 people off their asses than moving and make the biggest difference in population terms. When you hear people talk about, we did talk about Zone 2, or whether it's whether it's recovery or whether it's risks of too much exercise. I think there's a tendency to try to find a unique, a USP almost of like I've got a special, Zone 2 is probably, I don't know, Peter Attia and Huberman and these type of guys, it's like that's what they talk about.
Prescribing specific heart rate zones and specific
power output at a specific heart rate. And if you get outside of that,
millimolars, less than 2 millimolars of lactate per litre. Like you're like, what the hell does this mean to me?
Well, so I mean, on that example of Zone 2, I think well, it's not. I think that is wrong. It's actually wrong. It's wrong.
Please share. Go on.
Yeah.
Let's get into zone two, ladies and gentlemen.
Well,
go at it, because I'm fascinated as well. There's stuff I want to share as well.
Well, look, I'm a family doctor. I'm not a sports scientist, but what is zone two? I don't know. I know enough about it to know that I don't know. So
that's a great point. There's someone. Let's try to work out the histories. Someone, I reckon it was probably a treadmill manufacturer, said, "You know what we've got to do? We've got to make up zones for training, and let's come up with 5. Is 5 all right with you, David? Yeah, let's come up with 5. Zone 1 walking, zone 5 sprinting, and then we'll just separate the other 3 in between."
Historically, and from a sports science perspective, there was 3 sort of 3 zones that were described as and are reproducible. This is the difference; they're reproducible. So a sort of I can't remember the phrase they used. It was medium, severe, and extreme, or if you want a traffic light system, a sort of green, amber, red, and effectively, the first. Or the moderate intensity. I think it was moderate, severe, and extreme. And the moderate intensity was effectively up to the lactate threshold, and then the severe is from the lactate threshold up to the critical power threshold. And that's so you've got you can measure those physiological markers where your energy systems are changing over. So broadly, if you're going to be in the red zone, you're only going to do it for a minute or maybe 2 minutes. Your amber zone, maybe if you're a good athlete, you could stay in there for 45 minutes or an hour or a bit more. But then your early stages, you could do it for as long as you want. And one of the more I got into the weeds of trying to understand what these guys were talking about with zone 2, and it's there's no really clear, distinct definition in a 5 model. So they've sort of taken that standard physiological and said, right, okay, we're going to have stage 1 is this, stage 2 is where the magic happens, and if you're outside there, you lose out the benefit. Okay, and what is definitely true is if you look at elite performance endurance athletes, they spend most of their time doing low intensity exercise. Yeah. And you look at the stuff of the cyclists where we can measure, outputs with wattage fairly accurately. We know that they spend a lot of time, and there was this sort of adage of, go slow to go fast type of thing. And
build the foundation.
Build the foundation. Yeah. But we've actually, I've got more interest in this because we've done more and more VO2 max tests. And when you do a VO2 max test, so zone 2 traditionally, there's people describe it based on your heart rate, which is age dependent on heart rate. That's used. 220
minus your age, or sometimes you hear with the Maffetone model, 180 minus your age gives you the number.
Yeah, and those are...
in itself, David, sorry to interrupt, in itself, like just say Andrew number 1, 52-year-old that sits at home, watches television and eats Cheetos on the couch versus Andrew number 2 that exercises in itself. Again, bottom up, you're trying to give a mass a working place to start. But in practice, man, my 60 to 70% of my max heart rate in actuality might be Andrew A might be 120. Andrew B, that looks after himself and lives a good lifestyle as far as from a health perspective, might be 135. So there can be massive differences.
Exactly. And we know that the age metric just doesn't work. It's no good. There's the when you're doing the traditional way of looking at this is the peak of metabolizing fat. So you can measure when you're doing a max test, you can measure how much when you're metabolizing fat, when you're metabolizing carbohydrates, and it's the peak of fat metabolism is said to be your sort of zone 2, at least on that, using that metric. And then there's a ventilatory threshold, which is I quite like, actually, because you don't need to do a VO2 max test to do it. It's the point at which you can just about hold a conversation when you're going for a brisk walk or a run or something like that.
Another metric is just nasal breathing as well, which puts it sort of stop to the discussion, though, doesn't it? Sorry, mate. Yeah. There's two tests. One of them is that we need to be able to have a conversation, but the other one says I've got to breathe only through my nose. So, but they don't match well.
They don't, and that's. I think the most important message from a population perspective is find something that works for you. So that's why I quite like the ventilatory threshold. It's like if you're going to be somewhere around the easy zone, you're in the green zone if you can still have a conversation. But what the sports science shows is the maximal signaling to boost your mitochondrial function, which is what we're talking about when if this is about building energy systems, because at its most basic, zone 2 is supposed to increase the effectiveness and the numbers of mitochondria. They're like, for anybody listening who doesn't know, they're the sort of factories or the powerhouses in the cell that produce the coins that we use for energy. Yeah, they make the ATP that we use for energy, and if we can, we know that in chronic illness and chronic disease, inflammation, diabetes, cancer, heart disease, mitochondrial function is compromised, and so this is where it ticks over into the health end of the spectrum. If you can increase the effectiveness and the numbers of your mitochondria, you're going to be healthier and you're going to be fitter. From an athletic perspective, it's about how much energy you can produce, and the ATP is converted to ADP, AMP, and those little nuggets, the change that we get when we hand over our cash for our fuel, creates signals that makes more mitochondria. Yeah. But that happens at high intensity, not low intensity. It happens maximally when you're working really hard. So there's a conflict here. It's like, on the one hand, people are being told do loads of zone 2, because that's where the magic happens, and don't slip out of it because you're going to do harm. Yeah, and the magic happens at the point that you metabolize more fat. That's the maximal fat metabolism. So obviously, hang out there and burn the fat.
Yep.
The problem is this fails to recognize that you build more factories and you burn more fat in absolute terms if you get up into stages 4 and 5 and you're blasting it. And that's what happened when, remember, what was this guy called just 20 years ago, 15 maybe, when they first started producing this stuff around high intensity interval training.
Hit training, high intensity training, yeah.
And the it was so counterintuitive. We were told for so long that if you want to build your aerobic base, you've got to build a great big base and then do your intervals. But I'm sure we're both old enough to remember fartlek training. Yeah. And so I think I think the influencer dudes are wrong on this specific point. And I also I think two things. I think they're wrong on that specific point. You need high intensity to maximize your regeneration and optimal function of mitochondria. And I think they're wrong that they mix up the fact that you can train for health, you can train for fitness, and you can train for performance. And those are not always the same thing. Podegaard does, he's blowing out 320 watts in his zone 2 training. Yeah. Like, the guy's an absolute freak of nature. But, he does zone 2, and he there's an interview with him with I think it's Peter Attia where he talks about the fact that when he does 5 hours in zone 2, averaging 320 watts, and then when he's done that, he has to take a day off the bike. So that's tougher than a Tour de France.
Yeah.
So it's not, zone 2 for him is not a stroll in the park. Zone 2 for an elite athlete is high intensity, super high intensity for a non-athlete. And maybe zone 2 for a sedentary person is going down and getting a coffee, but
as long as the walk's maybe 20 minutes away,
and ideally, go to one that's a bit further away and walk there faster and walk up the stairs at the end, so you're out of breath. Yeah. So those, I think the idea, there's a danger that if you say to sedentary people, don't get out of this particular zone, that they're not going to do it enough. So I think the messaging is different depending on where you sit in the spectrum. That if you're at the sedentary end of the spectrum, get off your arse and move, and anything is good. Just move. And if you can get out of breath, even better. And if you can do it more, even better.
And the more you do it, do more a little bit harder.
I'd do it harder. And that's, do a bit of green and get the odd bit of red in there. That's
Often
the message.
now you'll hear the 80-20 percentages thrown out, and that's pretty valuable for someone as a point of reference.
I think it is, but
because one of the, and we spoke about this previously, one of the things that concerns me with the magic of zone 2, because I feel many of us, almost back to the Goggins comment, I feel many of us are not very comfortable at getting uncomfortable, and getting uncomfortable to the threshold that is bespoke to all of us is where the magic really happens. This whole longevity discussion is, yes, you need to burn fat in zone 2, and yes, you need to enhance your mitochondria, how many you have, and the efficiency of your mitochondria as well. But far out, you need to maintain your muscle mass as well. And in particular, as you age, if you just do zone 2, you're going to drop those fast twitch, those type 2 muscle fibers, and they're the ones that are going to go if you don't train them. And that's the beginning of frailty, is one of the measurements of aging. That's the beginning of the end, I would say. But part of how we started this discussion in the gym that day, my concern was with the soundbite that is social media of promoting that magic happens with zone 2. I just felt that we gravitate to hear what we want to hear.
Yeah.
So I don't have to work too hard. I can just walk, and as long as David and I can maintain a conversation, magic's going to happen. I'm going to get more mitochondria. I'm going to stay in the fat-burning zone. I want to be in the fat-burning zone. You know what I mean? My heart's going to respond positively to that. Wow, I'm going to push back these insidious diseases that David was talking about, type 2 diabetes, heart disease, obesity, by doing my zone 2, which indeed you will, but you just need to come over here and get uncomfortable.
I think that bit, I very much agree with like a lot of Peter Attia's stuff. The idea that in modern medicine, this is where we almost started, isn't it? We probably have focused too much on disease and pharmaceuticals, and even I think about the medical tests that I do. There's good evidence that like you've said, like we know that grip strength correlates with long-term health. But of course, there's other metrics of muscle mass and muscle power, but grip strength is one reproducible measure, isn't it? Whether it's farmer's carry or hang time or whatever you could, but being strong, so doing some lifting and preventing the sarcopenia of aging, absolutely. So strength. We used to talk about did you put the 4 S's back in the day? Strength, stamina, speed, and suppleness, which is
go on! I never got into that. Didn't make it to Tamworth, Australia, mate.
Flexibility,
suppleness, love it.
So I like that idea of.
Say that again, sorry, David. The 4 S's:
strength, speed, stamina, and suppleness.
Strength, speed, stamina, and suppleness.
Yeah,
brilliant.
That was one of the sort of fitness could be defined in there's loads of, but obviously muscle. Strength, power, muscle, lift, resistance. And then there's the aerobic. We're talking about the zone 2. We're talking about endurance and we know the VO2 max correlates well with long-term metrics of health. And if you look at the top 10 centile VO2 max, you're 5 times as impactful as being a smoker in the other direction. So you think about, we know how bad smoking is for you.
Yeah.
And that's how good being fit is for you. Yeah. It's if you're not fit, it's like you're smoking. Yeah.
We just need that. Do you remember those Grim Reaper advertisements?
Yeah.
Anti-smoking. We need a Grim Reaper type advertisement. Him 10-pin bowling against smokers and also against some sedentary people to move. Sorry, go on, mate.
Well, here's as a smoking. I'm coming towards I'm at the end reflecting on my career now. Yeah.
Yeah.
Probably there's a bias because of I trained in the UK, but if you're looking back on my career in medicine, I would say the 3 most important bits of epidemiological research that I can think of would be Dole, who was the guy who basically published the association with smoking and cancer back in the 1950s. The Black Report, which is social inequality in health, which is like the 1970s, and the London Transport Study, which was 1950. Yeah, so these are like, we've known this.
The London Transport Study, was that the guy with the brain?
No, so the London Transport Study is a brilliant bit of research. They followed 30,000 London transport workers for 10 years, and they were divided. Back in the old days, if you became a London transport worker, you got allocated to a bus, and you either drove the bus or you were the conductor that went around giving you tickets out and collecting the money for the tickets. And they followed these guys for 10 years, and they showed a doubling in cardiovascular risk in the drivers versus the conductors over a 10-year period. And then it was extended, it was followed. It's been like, that became the landmark study that showed if you don't move, you die. Okay, if you sit on your ass all day, you die. We've now, of course, seen more recently, there's lots of these sort of studies are coming out with wearables from, there's one in the British Journal of Sports Medicine just a few weeks ago that showed that the uptick in health benefits increased significantly after about 6,000 steps. The greatest benefit, it's like all of these things, the greatest benefit accrues to the people who've got the worst start point.
Yeah.
It's like if you're a smoker 40 a day and you can stop, you'll get a huge health benefit in a short period of time. And if you're, a lazy, sedentary person and you're doing nothing, in population terms, looking at the bell curve, the greatest benefit goes to those people who start to move a bit.
Yeah.
If you can get to 6,000 steps, that's great. And now at the big tail of the bell curve, maybe if you get your zone 2 up and you increase your high intensity and you get your extra shoes is a different thing, but you do all the ice baths and you do the you do the infusions and all the stuff that the sort of super elite centers. Yeah, maybe you get the extra 0.1%, but that might be the difference between getting the gold medal and not making the final. So
at that end of the spectrum, that's super important. Huh? At the other end of the spectrum, it's like, don't worry about the infusions and the ice baths. Get a dog.
Get a dog.
Yeah, seriously.
Go to dance.
Yeah, go dance.
Move. Don't worry too much about whether you're in zone 2 or zone 3 or how many zones there are. Yeah, get short of breath, at least sometimes. You've got to be a bit uncomfortable sometimes, work hard sometimes, and just move more than you were moving previously.
Yeah.
And then if you're into fitness, maybe, the people who are exercising to optimize fitness, and certainly those for performance, I would argue that you should don't get sucked into this idea that you lose benefit if you slip out of this zone 2, this magical zone 2 phase where you're not going to get the benefit. You know, why do I mean, athletes do it. Athletes do 80% of their training in zone 2. I think that's because if you're an elite marathon runner, you're doing 200K a week. Or if you're an elite cyclist, you're probably doing 30 hours of training. Like if you're doing 20% outside of zone 2, you're still doing 6 hours. That's a lot. Yeah?
That's a lot. Yeah.
And so you've got a threshold where if you're doing too much high intensity, you're increasing your injury risk. You're not getting adequate recovery. So you are getting benefits in zone 2. They're probably neuromuscular benefits. They're probably biomechanical benefits. They're probably
even we used to, and we still talk about it, but we used to, if you did a heavy session in the gym, what's today, Wednesday, so just say, David, you and I were going to the gym tomorrow and we're going to lift heavy, and we lift heavy in the morning, and then in the afternoon we do our zone 2, and we used to call that a flush. And at its very simplest, because I'm in zone 2, I'm pumping blood around my body, so that aids in recovery. What happens when I pump blood around my body as well? I will take lactate, for example, and then body can reuse that. They know they suggest that the brain can now use lactate, or can, it always could. But now they're suggesting that when you do a flush, you take what's called the byproduct of exercise and we put it back into the system and use it as energy, which enhances recovery as well. So we used to use, and still do, suggest you can do your low intensity training at the end, or give yourself a good resting period after your high intensity training to help your body slip into recovery fitter, better and faster.
Yeah.
As another way to use zone 2 on that end of the spectrum.
Yeah. Well, I think that fits into this. Sort of. It's almost like a three-legged. You got your recovery, and that's in its own right. You the way you train, the literal recovery in terms of time, good quality sleep, obviously hydration, nutrition, and then you got your loading at the other end, and then there's you training your energy systems, which I think is where this zone 2 discussion is really only about energy systems, isn't it? It's about mitochondrial function. It's like, what fuel are you going to put in there?
Metabolic flexibility is the term. And basically, if we condense metabolic flexibility down to what it means to you, it just means that your body's going to burn fat better.
Yeah.
Would you suggest? In the terms that it's spoken about.
Yes.
It can use sugar, yes, uses it very well. We all do that pretty well. And if you do some zone 2 cardio training, you're training your body to also have the flexibility to use fat as a fuel source better.
Yes, I think it's...
Oh, I love it when you take that big breath then, mate. Say it. What have I done?
No. I think it's maybe from a physiological perspective, it's a little bit more than that, because that ATP, ADP, AMP signaling pathway, the signals that it creates does a whole bunch of other stuff. It boosts the actual number of factories that we have.
The mitochondria.
The mitochondria.
But this is high intensity now you're talking about. You're out of zone 2.
This was at high intensity, sorry, yes. But and at low intensity, to a much lesser degree at low intensity. The signaling is much higher at high intensity.
So at zone 2, one of the benefits we say is you get mitochondrial biogenesis, meaning your body makes more mitochondria. But actually, when you do the high intensity, your body's making more mitochondria, more of the factories, is what you're saying.
The high intensity drives the signals that makes more mitochondria. Then you've got more mitochondria when you are then exercising at lower intensity. You're more efficiently burning in the fat zone and up to the fat threshold. So, you might be burning 50-50, or 60-40 to 50-50, or whatever it may be, depending on the threshold that you're working at. That's there's sort of 50% of what. So if obviously if you're working at high intensity or for a longer period of time, the absolute energy expenditure is going to be greater. So the advantage of going up into the high intensity is that the signals created change the way in which the proteins are developed from the DNA, basically. So this is sort of epigenetics. It's the control.
Genetic transcription, the stimulus driving what the genes are going to tell the body to do.
Exactly right. Exactly. Yeah. So the proteins are then transcribed to build the mitochondria and other things. But it's not just mitochondrial growth. It's the same signals that do that increase effectiveness of glycogen storage, glucose entry into cells, capillary size in muscles, so it increases blood flow and glucose entry into muscles, increases a whole range of cardiovascular effects as well. So it's almost like exactly the same signaling as, nature's developed a way that says, like when you know you're needing more energy, you don't just need more factories, you need a whole bunch more. You need more trucks, you need more roads, you need more. You need more workers. Yeah. So the same signal drives a whole bunch of physiological changes. We got to lay down more vascular beds to get more proteins here. Yeah, absolutely.
Yeah,
exactly.
Yeah.
So that's happening at higher. The higher intensity drives the change. The lower intensity does the higher volume is driven through at lower intensity because the whole system's more efficient.
Yeah.
Yeah.
Gotcha.
Does that make sense?
Yeah. And I'm just marveling in the brilliance of the body because you just, from insulin sensitivity to the stimulus coming in for the body to respond to the stimulus and says, holy cow, I've got to get ready because I think he's going to do it again. You know what I mean? Basically.
100%. And of course, that's what, insulin resistance is, which is at the base of many of these, pre-diabetes, cholesterol metabolic syndrome, blood pressure, early precursors leading to heart disease. These are early markers
inflammation.
of inflammation. Yeah. So if you drive those changes, but there's a physiological pathway which is easy to understand that explains how exercise drives positive changes that influence that. So if you've got, if I go back to my bogging sort of day job and I've got a guy there in his 30s who's overweight and is doing no exercise and has got pre-diabetes, I can give him pre-diabetic medications. We maybe, there's a variety of drugs that can be used early on, and if it progresses over into diabetes, we've got a bunch of diabetic drugs. Or we could get him in the gym doing some lifting and modified diet with a less refined carbohydrates and different times where we haven't really talked about there's all the stuff around fasting. That's a whole complex area. But whether you basically reduce calorific intake, change maybe what he eats, and when he eats, but most importantly, especially in the younger age group, what he does. You just fix the problem. You can drive exercise will drive a glycosylated hemoglobin or ferritin, or these metrics that we can measure in our standard blood tests, just drive them right back down to normal. Just every bit as effectively as
it takes a bit of work, doesn't it? That's all. Well,
it's a little bit of work
and a little bit more time. You just got to exercise. Patience is indeed a form of action, wouldn't you say, David?
Yeah,
in that context.
Yeah, completely.
Yeah, just keep at it, mate. Just keep at it.
Yeah,
trust me.
Well, also, that's the real challenge. Is it's a hell of a lot easier to write a prescription. Yeah. It's just so much easier to write a prescription than it is to persuade somebody to change their lifestyle. And
I often have this discussion with clients at Joint Dynamics, and I'll say, you're going to go pick Niall, a physio at Joint Dynamics. You're going to go see Niall, and our average client sees about a physio about 8 times. That's if you average. Some are seeing it 18 times. Some are seeing it 5 times, but it averages out, let's just say it's around 8, whatever, like that. And often I'll say to clients, when you see Niall, the physio at Joint Dynamics, he's going to give you some exercises to do. And let's just say he's going to give you 3 exercises. If you do those 3 exercises every day, he's going to ask you to, if you be compliant to the professional in this example while you're coming to see them, you probably will only see him 8 times. But if you don't do those exercises, you're probably going to see him 12 times, and unfortunately, our businesses are sort of, there's an element of your business is sort of run on people not being compliant because there's so many reasons, and I'm not attacking anyone for being weak, but compliance, and we sort of come back to almost round consistency is the magic sauce, not zone 2 maybe. Consistency might be out. We've got to start getting some sound bites out there about consistency and compliance. But if someone can find a way within their lifestyle to be consistent or compliant, which then takes that back to the onus is onto the professional to find a way that they can be consistent and compliant, and we can touch on dance or drawing stick figures and going back and having another touch point because that makes a difference in someone's life. Hey, David, client of Niall, Niall sends you a message. Hey, David, did you do exercise today? Those little touch points can also make a big difference in someone's compliance.
Yeah, it's very interesting. I think wearables will probably help in this regard as well.
Yeah, tech, in that regards, tech can be super helpful, can't it?
Yeah, as another feedback.
You set a reminder on your thing that we carry with us all the time.
Although it does tend to, it's like a lot of these things, isn't it? That the inverse care law of health, that the people who probably need it the least are the ones that have every possible metric. And they're coming
what do you do with that? What do you do all those days? Like, I don't know. I just like to know.
My HRV's 56 and I didn't sleep very
what are you doing with it? Nothing. I'm just going to look at it again tomorrow. Data to drive a strategy often doesn't work. I wanted to actually...
That's my favourite, the old triathlete at the party, isn't it? Where you can see that the person he's talking to is getting a bit bored and he says, anyway, that's enough about me. Let me tell you about my bike.
That's enough about my bike. Let me tell you about my watch or my shoes or exactly.
Yeah, my power output.
I want to pivot in the conversation for a second, and I want to go back to not within this conversation to a time where your wife came into Joint Dynamics, and she bought for your birthday present, Christmas present, wasn't it?
Yeah.
Christmas. She bought 10 sessions with me.
Yeah, that's
it was so great because I was at the front desk when she walked in, so we had a great chat. And then I wanted to say to you, sort of on compliance, you went through a period of your life where you weren't as active as potentially as you should have been. Do you feel? Is that an accurate statement?
She put you up to this?
She just phoned me. I just checked my phone. But can you share? Can you share your own?
Well, it's like
what happened though? Yeah, like that's a genuine. I feel that's a genuine positive sharing for you to share. If you don't mind, like you can throw some shit at me, David. I've got
no. But that's like I'm hopeless. I mean, you can.
Not anymore. You're not far out. You're in the gym. You're making progress. Working out with Ben twice a week.
Yeah, I do, and I love it when I work out. I guess like a lot of people, I was a team sports guy. Really, I loved team sports, and then had then because family and my kids, and
four boys, everyone.
4 boys, and
you've got to stay strong, mate.
You got to stay strong, and they're all keen.
And now a grandkid.
And now a granddaughter, and so getting to the next stage, and I was involved in coaching, so that kept me active, and being, always the kids were always really physical, and I guess I reached a stage where I got a bit lazy, and I'm very aware that if I'm not exercising to a certain threshold, I get a bit mopey and a bit miserable, and And Murray's pretty good at telling me, you're a lazy fat
slob. You're married. She's like, oh God.
When it's time to do something when your wife buys you some personal training sessions for Christmas. It's like...
That's love right there, mate. That's love.
But she's disciplined, yeah. So she'll go out and has always been able to go and get up early and go to yoga and go to gym and do fit stuff like 5 times a week. So I've part of the problem is I spend a lot of my time with reasonably fit and active people, and I tend to just like reflect onto them. It's like I have all these athletes coming in my office, so I think I must be doing all right. But
Via osmosis, this is just coming in.
He's training for me. Yeah, it's like I'm going.
If only. If only, mate.
If all the guys I looked after could do my lifting, I'd be pretty strong.
Remember there was that, I think it was the Japanese research on skill acquisition, and there was there was the cohort of people that didn't actually do the skill, they just thought about it and they got better. Do you ever come across that?
Yeah.
So I don't know if it works for the development of strength. And
I think visualization is quite interesting, isn't it? There was, I think that back in the day, the professor from Hong Kong U, I just had a mental block. His particular interest was in intuitive learning, and I got really fascinated. And I spent a lot of time talking to him at that time, and I think I mean, there's a lot more to it than that. A lot of that was around distractibility. Stuff with golfers is very interesting. If you get them to focus on a task outside of their putting task, they get better. Have you seen that data?
No, I haven't.
So if you get them, if you get golfers to, when they're putting, to, and you give them two sort of different tests from different distances. The one is you say, right, you got 20 balls from 20 feet, 10 feet, 5 feet, whatever it is, and it's the most the most important thing is the number that you get in. They say, concentrate on those 20 balls, take as long as you want. Or you then go and you say, right, here's 100 balls, hit as many as you want, you've got a minute. The accuracy in the second group goes up. And then a subgroup of that is if you get them to putt and put in a third task. So I remember he was telling me that he would use like a cone behind, so like a red cone or a yellow cone. So you've got a putt and also say whether it was which cone he was holding up.
Red
and again,
or yellow.
Again, the accuracy goes up. And that's just not quite intuitive learning. This is distractibility, but my simple understanding of the concept is that it was about sort of switching off external unnecessary noise, and that it was reverting to the focused skill which had been acquired through hours of practice. So you're not going to be too tight. If you're too tense. I remember one of our old.
I would say that you're very skillfully taking the attention away from yourself. That's what I would say to you. What I want to do. Sorry, but screw you, everyone. What I wanted to say was I was starting to think on this conversation between what we've just had and everything you've discussed, and then thinking that, well, you qualified as a doctor in 1984. And you made a comment not so long ago where you said you'll come to the part of your career where you're reflecting more, which sort of maybe one can say, does that mean he's come towards the end of his career? I would ask you, is that it? And then I would ask you, what's next for you? Someone who's obviously highly intelligent, highly curious with the world, and you love rugby. You've got 4 sons, and you've got a granddaughter, and all this sort of stuff. I was also wanting to find out from you what's next. But before I find out what's next, I'd like you just to share what have been some of the benefits, because part of this is to get people to move. And you, from a personal perspective, just say most of the times you're doing 2 sessions with Ben, and then now you've moved out to the beach and you're getting more time walking around, spending more time in nature as well.
Yeah.
Have you noticed a difference, let's just say, since you've been, I'm not saying you weren't a regular exerciser, David, but you weren't a regular in the gym. And via that we can quantify you weren't lifting heavy things very often previously. Is that right? Is that an accurate statement?
Yeah, no, that's right.
So now you are lifting more heavy things. He's doing more resistance training, everyone.
Yeah.
What are some of the changes you've noticed in yourself?
Yeah, definitely. I would say over the last 18 months, I've lifted more than I've lifted for years. And
For the previous 18 years.
Yeah, probably since last time I was trainer. I was never a great trainer, to be honest. I didn't like training. But
what are some changes you've noticed in yourself? Is there any?
Oh, for sure. Yeah, I feel sleeping better, generally feeling more positive, feeling just generally fitter and happier and healthier. Yeah.
Nice. God, there's a soundbite right there.
Yeah, I don't know how
Generally
much of
fitter,
that
healthier and
is.
happier.
I don't know how much of that is lifting. Definitely, I really enjoy the lifting and the resistance. I've interesting metric. My since I moved out to Sheko, my background movement has increased by 30%. So
There's your zone 2 right there, mate.
there's my zone 2. So
10,000 steps a day or zone 2, which is it? Well, I don't even know. It doesn't matter.
We have a little walk up to Big Wave and around the loop and back over the beaches. Marie and I do that probably four times a week.
Do you have a dog?
No, I was looking after my son's dog for about 5 months, and that really kick-started because I was walking on the beach then 3 or 4 times a day. But it
is a great suggestion to people. If you want to move more, honestly, get a dog.
Yeah.
And look after yourself to the same extent in which you would look after the dog. You know what I mean? The way that we look after a dog. Oh my God! My missus never. My wife, very Australian, wasn't it? Excuse me, everyone. My missus, my wife, grew up, never had dogs, and we got 2 dogs now. And the love, she's a feeder. My wife, she's Italian, obviously, so it makes sense. The love she gives to these dogs, and I think it's one of those things that people can connect to, and you just say, look after yourself to the extent in which you look after your dog. You know, you take your dog out for a walk to look after it. Part of it is go to the toilet, but you get all these benefits and you look after the way that the dog lives, and we care so much for it, but often it's easy for us to neglect ourselves, I find.
Yeah, you meet a lot of people when you got a dog, don't you?
Oh, mate, the social aspect.
I hadn't realised that until I looked after.
It's like when you got a baby, isn't it? Do you remember when you had a baby and you walk around, people would just come up to you.
Yeah.
Oh my God, Ocean Park, people would pick your kid up and take a photo. I was like, hang on, not like that. But when you got a kid, people would come up to you. I found, because our first dog was an adoption, we adopted this dog from one of them amazing dog adoption agencies in Hong Kong. Like there's some Mother Teresa-like people looking after dogs in Hong Kong. It's amazing. And we would go somewhere. People would just like we had a baby. They'd come up. We'll make it all friends because we've got this dog. Oh, where'd you get your dog from? Oh, it's an adopt. Oh, you adopted your dog. And then there was this whole sub-community that we became a part of.
Yeah, problem with the dog is travel. You know, we travel a fair bit.
Yeah, it is hard.
That is
hard.
That's the difficult one. So that's the rationalisation.
Yeah, fair
for not having a dog.
So did you finish, sorry, because I cut in again, did you finish on the benefits? You said it was multifactorial. So is part of that, though, because you train with Ben and he's such a great bloke and he's got incredible interpersonal skills.
Yeah.
Is part of that, do you think, the benefit?
Oh, for sure. I mean, the individual, yes, it's tough finding a trainer that talks more than I do, actually.
You've nailed it. High five to you, Ben. Joint Dynamics, we got everything, mate.
Yeah,
we got everything.
And I managed to find one, and then he works me hard enough that I can't talk, and he talks at me for it's great. An hour goes by, and do you know? It's interesting. I find that's one of the things I find with. I used to do. Yeah, I say used to do. I still do, but I did yoga twice a week. I had a fantastic yoga teacher. She's absolutely brilliant, and. But she would always, and I loved the feeling I got out of yoga at the end of it. But I never really enjoyed the process. You know, it was, and it was quite funny because I did a session just last week, and the same thing happened. I got 10 minutes in, and I thought it must be 10 minutes to go, and I looked up at the clock, and she caught me looking at the clock, and I was like, oh my God, it's like. Time stopped again. It's like,
We've slipped into an alternative universe.
When I do yoga, I find an hour takes about 3 hours to go, and when I lift weights, it goes in about 15 minutes. So that's I've always.
Well, there's 2 of your S's, mate. There's strength and there's suppleness.
Yes. So, yeah. I mean, yoga's fantastic. I would encourage anybody to the flexibility and the positional awareness of proprioception. You know, we're like unfortunately reaching the age where. falls prevention becomes
a
key,
massive
from
thing,
a health perspective. You need to maintain, and injury prevention, even for young keen sportsmen, it's like you've got to have balance or you're going to get injured. So positional awareness, balance, proprioception, movement patterns, all that stuff we talk about, it's effectively neuromuscular training, isn't it? So, that.
Here it comes, mate. Hey, here it comes. Sorry to interrupt you, but we've got to get to it. What's next? What do you reckon?
Oh, that's,
What's
know
next?
what, I
You've had an amazing career, like 1984 to today. Your business, started with how many?
I was just Tim and I, actually.
Tim and you. So, and then now,
bigger
you've
than
probably
that,
grown.
Yeah, we're going beyond but quite a bit.
Would you say you have 100 doctors?
No, I don't know. It's big enough, and lots of great practitioners. But I would definitely want the practice to keep going. I get a bit not frustrated with you asking that question, but I know I do get a bit pissed off when people say to me, because I get asked every day now, are you going to retire? Yeah. I still love my job,
Yeah.
But and I still like working, but at the same time there are other things to do. I mean, I've just had, my granddaughter's just been over, and I thought, that is so special. I can't tell you how special it is to go into that next stage. So there's other stuff. I love teaching. I love writing stuff.
But sorry, if you don't, I actually wasn't alluding towards that you should retire. I was thinking, with your experience, is there a chance your thought process is to become more of a mentor in some regards as well? Or it would be a shame for you from my perspective, and someone else that I own a company as well. I think it'd be a shame for you to walk away. Not saying that you are, my God, and you can.
Yeah.
But I feel that if it was me looking at your company, I'd say David's value is seeing clients, because he's very well trusted and obviously very good at what you do, and you're still curious and doing well. But also I see your value could be as a mentor as well. Do you guys talk, you and Tim ever talk about that?
Yeah, I do love teaching. I teach it. We're a teaching practice through Hong Kong U, so I teach younger doctors and.
Is that fun?
Yeah, it's great. I love it. I love it.
Get a bit of the energy from the up and coming people.
For sure. And it's different, and it's so different to the way it was when I started teaching it in a TB clerkship. I'm trying to look back now, probably 1991, and the students are so different now.
Can you quantify a little bit?
Much more. Hong Kong U has a problem-based. It's a fantastic university. They've got obviously very, very smart young people. So you're dealing with really, really bright young people. It might be a little bit in the way that I've changed, and there may be a bit of biases here, but I would say my memory of the students back in the day is you couldn't really get engagement very easily. You didn't get people to challenge. It was a bit more of a didactic. The teacher taught and the students listened, and they never questioned. And now, they're much more likely to question. It's still Hong Kong being Hong Kong, still pretty respectful and polite way, but a greater sort of strength of purpose. I guess we've seen that obviously the unfortunate things have happened in the city over the last few years, but I think the students.
Pretty tough, this place to shit we've been through, wouldn't you say?
Oh yeah,
the observation of Hong Kong.
Yeah, and
oh my God, we get through this past 8 years. We can get through anything.
And the young people, of course, the student population. They were at school. And then university, during the civil unrest, and then during COVID, so it's had quite an impact. But it's I love teaching students, and they're so smart though. That's way smarter than when I was I don't think I'd be able to get in nowadays.
Turn back the clock. Hey, I think to summarise, to come to an end to this conversation, if you review everything we've talked about, and then sometimes if you review, maybe if you did some preparation. I did, and I didn't even look at any of it. which is so great. What would you add to the conversation? As a doctor of the amount of years that you have and what you've seen, and, we spoke about many things, but if there's something that you thought, you know what, Andrew, I'd really like to share this, what would you add?
Oh, gee, you stumped me there.
First time. Jeez.
Yeah.
You got the shits with me when I brought it back to you, which I appreciated. Fair enough.
No, I mean, I get it. The one of the things that, if you to say the one lesson I would pass on to the younger doctors that I teach, it would be, we talked about transferring control back to individuals, not not taking control away from them, facilitating their own journey, I guess, in that way, but also encouraging people to tolerate and understand and appreciate uncertainty. Because one of my beefs about the sort of modern shift in the world is I think we've moved towards an unreasonable illusion of certainty, and I think the government does that too much in Hong Kong. We saw this during COVID, this idea that we're going to eliminate risk, and by attempting to eliminate aspects of risk, we created way more risk. Yeah. I see it every day when I walk past in Sheko, the signs, no surfing on Big Wave Bay.
That's crazy. Isn't it?
It's insane, the idea that that we've created, boundaries, that living in gated communities and buying insurance and whatever it might be, there's sort of an illusion that we can control external events. Whereas in fact, if I look back, it's like jump in, embrace the chaos, and accept that things are going to be. There's going to be risk. There's risk in everything that we do. It's a question of you can mitigate it, but you can't eliminate it. And if I now look at the joy I had see from my granddaughter, and it's one of the most amazing things is watching all my boys, actually, because it's great. They all love her, but watching my son who's got the baby, and he's definitely embracing risk. We were in the sea with her, throwing her around on Boxing Day, and I was looking at that and thinking, this is a great, you've got to expose young children to adventure and excitement, and don't be afraid. Squeeze the marrow out of life.
Oh, mate, I think that's a great place to finish on it. Squeeze the marrow. All right. Hey, thank you so much for coming and hanging out, David.
No worries.
It's just fun, isn't it?
Yeah.
Come and having a chat. Josh, maybe you can come into the gym with us on next Tuesday and film this again. We just do it every Tuesday or Thursday. You and Ben. You and the Ben show. So thanks a lot for coming in, mate. Thanks for sharing.
No worries.
And thanks, everyone, for hanging out with David and I. I'll be back in 2 weeks with somebody else as cool as David, hopefully. See you guys.
Bye.